And good afternoon, everybody, and welcome to the Center for Practice Excellence Speaker Series. My name is Zubin Austin, and I am the Academic Director for the Center for Practice Excellence, and it's my great pleasure to welcome you to our session today. We have a very special guest speaker today, Mike Sullivan, who many of you will know. I hope you are also aware that Mike is this year's Leader-In-Residence at the Leslie Dan Faculty of Pharmacy. Our Leader-in-Residence program is a relatively new program. Mike is our second Leader-in-Residence, and it's an opportunity for leaders in the field to connect to students, to share their expertise, to work with faculty, and to present to our diverse communities here at the Center for Practice Excellence. Mike's work as Leader-in-Residence has resonated widely through the faculty. He has been incredibly generous with his time and talent, and so we're very appreciative of the opportunity to take even more of his time today at the speaker series. Let me turn it over to our administrator for the center, Annalise Mathers, who will do our land acknowledgement, introduce Mike, and get our session started today. Thanks for joining us.
Thanks so much, Zubin, and great to see a few more people trickling in online. It's great to have everyone joining us today. So just as a brief introduction, for those who might be joining us for the first time, the Center for Practice Excellence is based out of the Leslie Dan Faculty of Pharmacy here at the University of Toronto, where I'm based today. And we focus on pharmacy education and training, research, and practice and innovation. So our monthly speaker series is where we get to learn about and sort of discuss critical issues impacting the future of healthcare and pharmacy. I'll also note that this is our last speaker series before we take a brief break over the summer and then reconvene in the fall. Just before we get started, I just also want to take a little bit of time to acknowledge the land on which the University of Toronto operates, and like I said, where I'm based today. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. I recognize that this meeting place is still the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to work and learn alongside everyone else here today on this land. So as Zubin mentioned, we're really fortunate to have Mike joining us for today's event. Mike's going to take us down a bit of a different format for our event today and actually propose an argument for both sides of the question: is a service-intensive, care-focused model of independent community pharmacy practice financially viable? And so Mike's going to kind of walk us through both sides of that argument. And after that, we'll have about 15 or 20 minutes for some question and answer with our audience joining us today, so everyone on the call. Just a few quick housekeeping items before I turn it over to Mike. I'd just like to remind everyone that our sessions are recorded and posted online onto our CPE YouTube channel, as well as on the LDFP website. While Mike is presenting, I'll just ask that you please keep yourself muted, but cameras on if you're comfortable, and just kindly put questions or comments into the chat. We'll get to those at the end of the presentation, but when we get to the portion where we have audience Q&A, I think I'll just also invite people to, share, turn their microphone on, and also have cameras on so we can have a bit more of an interactive discussion. Mike, I think Zubin did a wonderful job of introducing you. So in the name of time, I think I'll pass it over to you to get started today.
Terrific. Thanks, Annalise, and thanks, Zubin. Good afternoon, everybody. It's a real pleasure here as I'm winding down my academic term as Leader-in-Residence to be involved in the CPE webinar series, and we're hoping this is going to be an event that we can use in a conversation that may be able to seed sort of further conversations as we move forward. That said, given the nature of the conversation around financial viability of patient care-focused independent community pharmacy practice, I think it's just important that we start off. So I'm not an employee of the university, and that's by design. The Leader-in-Residence is intended to be an external partner for a given academic year. So I'm not affiliated with the university other than this appointment and being involved. So my opinions here and what's discussed and presented are certainly my own and not necessarily reflect the views of the faculty, the CPE, and or the broader university, and or Cubic Health, which is the firm that I work with. And we have We have a team of, I guess, close to 30 pharmacists now that work at Cubic, and so I don't want to be speaking on their behalf either. So I just want to make sure that disclaimer is out there, just so that everybody knows this is just an intent initially where we want to sort of make a case on both sides of the argument and then open up a broader discussion. I will say I am a second-generation pharmacist. I'm the son of an independent pharmacy owner, and so I've had a many decades relationship with independent community pharmacy, and while I don't practice in that space currently, it's really nice, and it's special to be talking about this from this perspective, having given its relationship to me personally over the years. So the questions that we're really exploring here today is the service intensive care focused model, is it viable today? And if it isn't viable, what are some of the next steps that need to happen for this to become a reality? The goal here is, obviously, we're not going to solve the issue magically, any of the issues that do exist magically in the conversation in the next 45 to 50 minutes. But I think what would be really helpful as we get into some of the conversation, I welcome all your comments and feedback. And many of you may have very different points or additional points to add, or feel very strongly for or against certain things that are presented, and that's great. Please feel free to throw out any commentary you wish, but what we'd really like to take out of this is there some path that's emerging here where CPE can sort of think about how this could affect future discussions and future panels that get together. But then more importantly, more broadly, how does the University of Toronto, how's the Lesley Faculty of Pharmacy kind of get involved in helping to sort of facilitate where this could be going on a go-forward basis? Because obviously the university and the faculty have very unique strengths around their independence, the nature of the staff, the human resources, the research resources, et cetera, that are available. Where can we be focused, or where should we be focused moving forward? And then, of course, one of the things is to try and understand, is viability of that kind of model, of a service-oriented model, is that the key issue, or is the key issue actually the sustainability of the model? And so I think one of the things we'd like to kind of get to at the end of the day is where do we land in that particular realm? Again, so we can start to think about, where does this conversation need to expand moving forward? Maybe just a little bit of initial context, recognizing that, there are different jurisdictions here in Canada, and obviously very different, I guess you could say, methods and philosophies of pharmacy service reimbursement and their structures, Alberta probably being at the very leading edge of it, and some of the smaller provinces maybe being at the tail end of jumping on board with some of this. We're going to focus our conversation here today on Ontario, recognizing that it doesn't necessarily reflect the entire country, but let's use the jurisdiction of Ontario as we get into some of these more key specific issues. The other thing too is, I think it's really important for us to think about right up front that the viability of going from product-centric pharmacy practice at the community level to a reimbursement model that's service-based and is a global challenge. And it's by no means unique to the conversation here in Canada. Here's an FIP, the International Pharmacy Advocacy Group. This is a statement policy of theirs from September of 2020, where they're talking about sustainability of pharmacist-delivered professional services through viable remuneration models. And they've got a 5 or 6 page statement policy there. So clearly, this is not something that we're dealing in a North American or even a Canadian context, which I think is helpful, that we don't have to feel pressure to have all the answers right now. And if this was an easy nut to crack, it would have been cracked a long time ago. Also interesting, I think, is, and some of you here in the audience may have been involved in some of these conversations once upon a time, but it was really interesting to go back and do a bit of research to understand that some of the more formal elements of this actually took place under the Canadian Pharmacy Services Framework, or CPSF, that was developed nearly 15 years ago by CPHA, the then CACDS, and various provincial pharmacy associations. So it's, first of all, kind of interesting to reflect back on the fact that we are talking about, 15 years ago, or close to it, when some of this framework was being formalized in different areas. And I guess we could debate, the trajectory since that time. But clearly, this is not a brand new issue. But what they did was actually interesting and helpful from our conversation here, because the CPSF really outlined 3 different areas of practice and sort of reimbursement areas. The first is core dispensing services. The second is enhanced medication-related services, which they sort of defined as adaptation, therapeutic substitution, that sort of thing. Anything related to that specific prescription or claim for a given member fell into that second category. And the third category is probably where we would see all the rest of the service-based pieces filling in, which was things like comprehensive medication management, akin to the meds check type of program, management of minor ailments and health, and then getting into health promotion and disease prevention, which is kind of interesting because that's a very broad and significant category. And so those were actually, thinking about this a bit more, those are really interesting, and I think very thoughtful buckets, because I do think they encapsulate most of what's happened to date and where things will be going in the near term. And I think it's a good framework to be able to sort of build off of. Now, if thinking a bit more about this framework as some initial context, they define these expanded patient care services under comprehensive medication management. It was obviously drug-related problem identification and resolution, care plan development, ongoing monitoring, following up, the assessment, triage, treatment, and monitoring and follow-up of minor ailments, and then getting into things like immunization, disease screening, smoking cessation, and something that was termed wellness or lifestyle. And I'm not entirely sure what was meant by that, and where sort of pharmacy would start and stop in their kind of thinking. But these are all of the sort of the expanded patient care services that they defined in their framework, which again, I think is very aligned with where the world has evolved in the last 10 to 12 to 15 years. Again, just for basic context, for those that aren't looking at this on a day-to-day basis, you'll be familiar with some of the reimbursement for meds checks here in Ontario, the med checks diabetes, the at-home visits, what pharmacies are reimbursed for mild ailment prescribing, pharmaceutical opinions, and then getting into smoking cessation and things like influenza vaccine administration. I think we can all take a look at these reimbursement numbers on the right-hand side, and there's probably a couple of conclusions that we can draw that are fairly concrete. And number one is, it would be fairly hard to suggest that these would be the reimbursement levels that would be feasible long run when we think about a hyperinflationary world that we live in. And so we'd have to be thinking about, what do some of these reimbursement levels probably need to look like down the road? And then secondly, the fact that many of these have not changed appreciably since the services were first introduced. And in some cases, I believe the meds check introduction goes all the way back to 2007. And I don't believe these figures have even come close to keeping up with sort of base inflation, to say nothing of the sort of hyperinflationary world we're dealing with today. And so it's an interesting context frame to see what's there, and then think about where these may have to go moving forward to address some of what we're seeing just from an overall cost to operate today. So first up is the case for the viability of the model being a model of pharmacy practice that can be centered around the provision of patients-focused services, clinical services, cognitive services, whatever title you want to put to that, as opposed to a model that's focused primarily with revenue being generated from core dispensing. So the case for the model, and as we're going through this, be really helpful if the audience, when we get into the discussion, if you have very different or additional points you'd like to add to sort of both sides of the coin, because I think it would be nice for us at the Center for Practice Excellence to start sort of building out a bigger inventory of what the for and against is, and strengths and weaknesses, as this conversation needs and should gain more traction moving forward. So I guess the case for initially is that professional services have been reimbursed now, here in Ontario we're now approaching 15 to 20 years So it's not, it wouldn't appear to be something that was just an initial response to price changing or whatever the case might be, but something that's obviously now an established precedent. The minor ailment prescribing in January 2023 and the further expansion that same year suggests that there is, clearly a lot of demand for and need for this kind of service, where we need to have pharmacy helping to address the primary care crisis that exists in Ontario and obviously nationally post-pandemic, that there's a greater need more than ever to reduce the burden on the healthcare system, and a very clear awareness that pharmacists and pharmacies are profoundly underutilized and are an enormous asset moving forward. I think anybody who's looking at this from a very positive perspective would say, isn't that amazing that in the span of basically 9 or 10 months, we went from 13 to 19 minor ailments, just like that, and without the kind of pushback that maybe we would have expected once upon a time. And, necessity being the mother of all invention, it's not as though this primary care crisis is going anywhere, and we're going to have to find newer ways to be innovative and deliver health, not fewer ways, and or sort of retreat back into where we were. And what other healthcare asset outside of our network of community pharmacies across the province and across the country, which again would be dominated in number by independent pharmacies, if you want to include, banner groups and buying groups and things like that into that model, that's obviously, this is the greatest asset, to be able to render services in a world where the primary care landscape is profoundly cloudy and negative. I reread the Globe and Mail article from December 2022, partly because the Globe seems to be fascinated with pharmacy these days, and also partly to get some value out of my digital subscription. But going back and rereading the article in 2022, when they did the in-depth assessment of primary care and what was going on with physicians, these numbers are actually stunning, and really concerning. And in the span of the last 3 months, my brother, who is a cancer survivor, and my father, who turns 80 this year, both living in separate urban regions, both lost their GP, and are having a very difficult time finding an alternative situation. And so when we see that, 1 in 6 family physicians are over the age of 65, and that 1 in 5 Canadians do not have a GP, those figures are obviously really concerning, and they probably are understated now, because this is December 2022. Fast forward nearly 2 years, and this picture isn't any better. But one of the things I thought was really interesting for this conversation, and this arena being an academically based, independent assessment of some of these key issues for the Center of Practice Excellence, is there was a very puzzling decision made in the early 1990s to reduce enrollment nationally in medical schools. And that was supposed to be a cost containment vehicle for the healthcare system. It's something I want to read into a bit more, because it's just fascinating to kind of dive into it. But it is very clear that very short-sighted decision to reduce enrollment by, I believe it was a minimum of 10% for an extended period of time, has created this enormous gap of physicians that are experienced, that are sort of in that 45 to early 50s age range. We've got this hole where we have, that proportion of family physicians in their 40s is substantially declined over time. And that's, I think, a lot to do with some very short-sighted policy decisions that are coming back to roost now. And so we can't be making those same kinds of mistakes on a go-forward basis as it relates to primary care. And then another thing that seems to be gaining a lot of traction, especially in pharmacy social media circles, is early returns. And one of the earliest returns, and the most cited one of recent weeks, is the statistic that emergency room visits in Nova Scotia for minor ailments were down by nearly 10% in the most recent year. And they attribute a significant chunk of that to the fact that also aligns with minor ailment prescribing by pharmacists in the province. And so there's a lot of energy now being pumped into the fact that, wow, this is great news. We should be expecting to see similar types of results elsewhere. And imagine what this is going to do to continue to boost the case, to further enhance and further fund services through pharmacy, that will enable enable access to members of across the province of all age groups. And these are some of the outcomes that will benefit the healthcare system as a whole. So nice to see some of these results coming to light and being published, and hopefully there'll be more coming. The pharmacy demographic piece is also an enormous strength and a case for the viability of the model of patient-focused and pharmacies that are driven by service-centric revenues as opposed to simply product distribution-centric revenues. And according to data that was published by Statista, the number of pharmacies in Canada increased by 30% in the last decade. In that same period, the population of the country only increased by 10%. So if we look at that, we can look at that positively, say, number one, the underlying economics of pharmacy are clearly strong enough to support this expansion into a service model. And we can leverage some of the strength of the existing distribution model to be able to further catapult that. And then secondly, the increased number of pharmacies by 30% in that period again shows that we have all of the underlying infrastructure to be able to very easily scale more and more and more products and more services, I should say. And that is evidenced by the fact we went from 13 to 19 minor ailments prescribed in the same year in Ontario, as an example. Those are really strong statistics, again, to really support the case for the viability of this kind of model today, and of course to expand it moving forward. The other interesting part of this, and the other interesting case for the viability of this model, is looking at IQVIA data and looking at census data or population census data from the United States. There's roughly one community pharmacy for every 5,600 Americans. That number in Canada is 1 per 3,300 Canadians. So we've got this accessibility to pharmacy, which is a huge asset here in Canada. We don't have significant quote unquote pharmacy deserts like exist in the United States today. And that have been sort of increased by some of the closures of pharmacies because of competition, economic issues in the United States and their system. But we clearly have a far more densely populated array of community pharmacies across the country and across the province of Ontario. Therefore, we have the infrastructure here to be able to move up and take on more of this primary care concern and do so with relative ease, given that these sites exist. They don't need to be created, they're already out there. And so there's more and more ease to be able to reach more and more Ontarians or Canadians, depending on your perspective, who we're talking about, given where we're at today. And then lastly, internationally educated pharmacists account for 30% of pharmacists. And in Ontario, that number is actually close to 50%. And so as a result, we have been able to scale the growth of pharmacists in Canada and obviously here in Ontario. And we've been able to do that through international education in a way that medicine, for example, has not been able to do. And the stories of foreign trained physicians not being licensed in Canada is a story that's been told many times. And clearly we've gotten around that with some of the infrastructure we've built in pharmacy. And then because we've had such a strong influx of internationally trained pharmacists and educated pharmacists, approximately 45% of the pharmacy group is under the age of 40, which again is wonderful from a demographic perspective when we compare that to what we're seeing from the physician perspective, when we've got so many of them already practicing into their 60s and probably very close to retirement age if they're not already there. So we've got these demographics as really strong tailwinds as to why this is a viable model today and will continue to be such, because we've solved the demographic crisis from our pharmacist profile that other healthcare professions, in particular medicine and primary care medicine, haven't been able to do. So those are some of the key points for the viability of this model. And again, I would encourage you to think about some of the other things that may be top of mind that that get there, and that you would add to that conversation. Now we get to the second side of the coin, which is the case against the viability of building an independent community pharmacy model where revenues are driven through the provision of services and cognitive services and clinical services, as opposed to revenues being made to the distribution of medication that's part of the core dispensing function that we talked about before. The first one, the case against it is the inverse of what we just talked about. It's the crumbling primary care infrastructure. So in other words, how are we supposed to be integrating pharmacy services seamlessly when in particular thinking about things like meds checks and comprehensive medication management, things like this? How do you do that in an environment where the primary care infrastructure is literally degrading by the day? So who's going to be accountable for care plans? And who's accountable for actually resolving drug-related problems if we've got limited prescribing by pharmacists still in jurisdictions like Ontario, and an ever-growing number of primary care barriers? So yes, primary care is a tailwind when we think about the fact that there's not going to be a knight in shining armor sort of riding through and saving the day there anytime soon. And they're going to be looking for innovative models to be able to bring care to Ontarians and to Canadians more broadly. But if we don't have alignment in terms of authority, and we don't have and we rely on some of our partners in the primary care infrastructure to be able to actually help us resolve and deal with some of these issues and have accountability for it, what good is that if we can't get that done? And so that's sort of like at the top end, a very, very significant infrastructure concern today. The second case against the viability is the pharmacist and pharmacy technician labor shortage. So, nobody knows if this is chicken or the egg or what's happened. It's obviously a very complex problem. Yes, we've had a growth in the number of pharmacies of, say, 30% over the last decade or so. And that's put a strain on labor shortage because the number of sites for pharmacists has increased over time. But the challenge is we have data that would show that there are 46,000 plus licensed pharmacists, but only 2/3 of those actually employed in direct patient care. And that number does not appear to be trending in a positive direction. In other words, there appear to be many pharmacists that are looking to move outside of frontline provision of care, dealing with patients, whether that be in the community or other settings, and into other forms of employment and in other roles. And so how does the shortage that we have today, and how does enhanced turnover, because there's obviously more people looking for another opportunity or looking to enhance their role, their responsibilities, and can move with fairly significant ease now given the labor market. If that's impacted pharmacists and pharmacy technicians, then how are we going to plan for sustainable delivery of these services if we can't even properly find qualified staff? And then secondly, if we can't delegate more and more tasks to, say, for example, regulated pharmacy technicians who can, in theory, handle the vast majority of the core dispensing area, freeing us up for those other two areas, if we go back to that framework we talked about at the beginning. And so if we can't necessarily lean on that, because that's becoming more and more of a challenge, how do we get out of this, and how do we solve it? How do we bring more complexity into our workflows if we have fewer qualified staff and less ability to delegate out technical tasks? Another case against this is the whole piece of, well, if it's becoming increasingly costly to run pharmacies, and we have to be able to have extended hours so patients can access pharmacies when they need it. They can access over-the-counter products, they can access prescriptions, they can access counseling for whatever they need. And we need to have sites. They need to be open when people need them to be open. How are we going to be able to scale, all of these services when we know that we're having a hard time with staffing, we're struggling on the labor side, and it's becoming more costly to run pharmacies because the cost of labor and the cost of overhead is continuing to rise? And so this idea of, well, could we not theoretically bring in independent contractors and this idea of like, do we have to be billing pharmacy services through a pharmacy? Why couldn't a PharmD or a registered pharmacist in Ontario who's Part A, why couldn't they effectively be an independent contractor and set up the ability to be able to bill for services directly? And theoretically, if they're bringing in patients through a relationship with a given pharmacy or set of pharmacies, they could theoretically share, some of that reimbursement back as part of a fee structure to the pharmacy that's incurring these higher operating costs. That isn't feasible when you think about the fact that the funding isn't adequate today. So if the cost of the reimbursement for a med check hasn't changed in many, many, many years, and we're in a world where we've got hyperinflation across the board, and labor costs are gone up, operating costs have gone up, and we're not getting any more money from some of these services. We're only at $8.50 for influenza vaccine administration, et cetera. That if this is the case, where's the money to be able to have someone step in, do some of these services as almost a full-time area of focus, scheduling, booking appointments, doing this kind of work, having that be viable, and then being able to share some of that back with the quote unquote home pharmacy or patient's sort of central pharmacy that is there and expected to have to carry the burden of operating in a brick and mortar sense to be able to service these members who come in who need what they need. So that becomes a very complex and challenging issue if the funding isn't adequate. And this model would argue that the funding is not adequate to be able to do that. More reward requires more risk. And so we talk about enhancing scope, but do we actually have a cohort of pharmacists in Ontario or more broadly in Canada that are prepared to take on added scope and risk so we can go past, say, for example, if we look at minor ailment prescribing as being a fairly basic service, there's not a tremendous amount of liability or risk when we're dealing with things like acne or conjunctivitis or GERD. What happens if we want to have broader prescribing authority and the risks that come with a significant adverse drug reaction or a medication issue there, or some of the risks that would come with legally from, for example, a pharmacy being accused of writing in its own prescriptions and filling prescriptions, and then there being an adverse event for a patient? What does that do? And is there more appetite for more involved, enhanced services that would theoretically, bring more value and therefore create more reward? Are we ready for that? And the sort of, I guess we could say, factual or a piece of evidence to that would be the Alberta model of additional prescribing authority has existed for something in the range of 20 years, and it has not been widely adopted. In fact, I believe it was only in 2019 or maybe 2020 that more than half of the pharmacists in Alberta had actually received that designation of additional prescribing authority ability. And so it's clear that there were many, many pharmacists practicing in that environment pre-pandemic that weren't interested in going down that path. Didn't really feel maybe the reward was there, the need was there, the risk wasn't exactly worth the reward, and that was different. And so what evidence do we have that there is a real appetite to take on more and take on the risks that come with taking on more? The next piece is probably the most self-evident one. If the services aren't funded properly, how could this possibly be considered a viable model if we're not there now with services being properly funded and there's no consideration for inflation? And does the lack of the inflation of even dispensing fees, if we go back to core dispensing and just look at that, because that's a pretty cut and dried process. Prescription is here, prescription is dispensed to the member. If we go back and take a look at the lack of increases in that fee over the last 20 plus years, does that point to a willingness of governments like the Ontario government to properly fund new services? if they haven't been properly funding existing services, like existing core dispensing services that haven't changed profoundly over many, many, many years. And so does it signal that maybe governments feel that pharmacies are already fairly compensated? So if we think that the dispensing fee that ODB plays pharmacies has only increased about 1% per year on average for the last 20 plus years, is that because governments feel that there's other revenue levers that pharmacy can access that effectively allow it to be considered fairly compensated? Does the government look at the growth in the number of pharmacies as a KPI to say, well, look, there's 30% more pharmacies in the last decade and the population only grew by 10%. So clearly we don't need to fund this anymore. It's doing just fine on its own. So if existing history of funding of services, and even if we look at core dispensing as any indication, what there gives anybody any sense of comfort that this will be properly funded moving forward now that these services are established. And there seems to be inflation everywhere except for inside the pharmacy. So, the cost of McDonald's food items in the last 5 years, in a widely circulated report of the US by The Street, seems to show that, some core menu items have had an increase of 70 to 120+% in the last 5 years alone. But we've only seen 1.5% increase in the dispensing fee paid by ODB dating back to the early 2000s. So how is this going to work if we don't really respect the concept of inflation with the services that we're already being paid for? The lack of data, and this is something where, again, I'm hoping that there's an opportunity here for a university infrastructure, and why these kinds of conversations are so meaningful in a CPE type of environment, is what happens in jurisdictions like ours in Ontario, where there's really substantial issues to accessing information that would actually allow for the provision of valuable clinical services. So for example, we don't even have a central medication database because our pharmacies aren't connected. How does that impact to what degree we can perform some of these services, and how we can look at and gain information quickly to be able to scale them up? If we don't have access to EMRs, et cetera, what does that look like? And so does this lack of data, does this really allow for meaningful expansion moving forward if we have to literally get on the phone and call pharmacies to try to put together the best possible medication history? Like, what does this look like when we can't go back in and see some of these things and deal with what we're dealing with? And so if we think about input data and impact data, which by the way are just terms I've made up, so I apologize if they don't make any sense. But if we think about input data, like what are some of the, like what medications is somebody on? What other conditions do they have? What allergies do they have? All that kind of stuff, where there'd be central databases of this information available, versus impact data, which we'll get to next, which is if we're not able to measure impact of what we're doing with pharmacy services because all of the data sits in different silos. And how are we ever going to then say, look, here's the business case for continuing to expand the funding of these services? And how do we get, private payers and other payers to start thinking about this as well? And so again, if you're arguing the case against the viability of this model, one could very easily say, well, the MedTech experience in Ontario would be a perfect gold standard around the really profound challenges that exist in measuring outcomes that would allow for the measurement of the return on this investment in these services. And so if we haven't had an easy way of doing that to date with MedCheck, and we have 15 years of experience with that program, how is this magically going to change as these services become more enhanced and more significant on a go-forward basis? When we think about scope of practice, we talk about the expanding pharmacist scope of practice, but is that actually the right benchmark that we should be thinking about? So, for example, if we think about how primary care is sort of falling apart, how is the current scope going to really change things? So if we just add, say, for example, more minor ailments to the experience, or, a little bit more funding to smoking cessation or things like that. Is that really what, are we comparing things the right way, or do we need to look at the scope in a very different way? So for example, there's an inability in Ontario to order lab tests, prescribe beyond that, or we even adapt existing prescriptions. So, again, how do we, how are we going to really relieve the primary care burden if we're not thinking about the scope of practice beyond just kind of quote unquote pharmacist scope, comparing to what we used to do, to what actually needs to happen in the broader primary care system, and where does that need to go, and go very quickly? And it would seem that it doesn't matter how much is being talked about getting into one area or another. If we can't do things like order lab tests, and if we can't do things like prescribe beyond minor ailments and adapt prescriptions real time, then are we just practicing with one hand tied behind our back? Who's going to pay for this and pay appropriately? It's great to see these provincial plans paying some, although there can be some debate about the reimbursement levels that are here, but at least they've stepped up to the plate and have provided funding. Where are the private payers in the equation? What exactly is holding them back? There are no private payers that are meaningfully today paying. Well, there may be, maybe one or two cases, but those are typically pilot projects and sort of test projects, but there are not widespread private payer reimbursement of these services. If you want to think about it differently, the three largest insurance companies in the country control 70% of the group benefits and health benefits market. So if we want to use that as the measuring stick, why haven't those three, or even one of those three, come down this path if there's a willingness to pay and pay appropriately to do this? And without them there, how do we then overcome some of the limitations of public payment where the reimbursement isn't where it needs to be? And more importantly, again, if you're arguing the case against the viability, how are we going to ever expect patients to pay out of pocket for certain elements of these services, given that people are more than willing to pay for DoorDash, 3 or 4 or 5 times a week, and all the fees that go along with it, and et cetera. But how we expect them to ever pay for pharmacy services when pharmacies are already commoditizing what they're providing today in the name of competition? An easy example that comes to mind is waiving the copay in Ontario, where it's, just zero financial barrier to people accessing medications. If we've made a habit of doing that, then how would that not happen if in fact we're in a world where patients were responsible for some portion of the payment of some of these services down the road? And what would that do to the quality of this? Then wrapping up, standardization of services. How do we standardize services? And have we thought about that really in a way that we can standardize dispensing, which is much, much easier when we're product focused? And in Ontario, where say 48% of the pharmacists are educated internationally, I think a key question is, does becoming licensed in Canada and passing Canadian board exams, does that equate to a desire and an ability to practice in a service-centric model of practice, which is a really important question when you're talking about half the workforce and potentially hundreds and hundreds and hundreds of academic institutions that graduated these healthcare professionals, for these fellow pharmacists. I think you could also expand that question to the, whatever it is now, 9 or 10 schools of pharmacy, faculty pharmacy in Canada. Are we also of the mindset that across the board here in Canada, do we also feel that we're sort of becoming licensed, in fact, is equating to a desire and an ability to practice in that model for our internal Canadian graduates? What does that look like? Are we sure about that? Have we thought about the fact that are we actually setting the funnel for people applying into pharmacy schools who are actually applying with the goal of working in that type of model and that type of area moving forward? And it's easy to talk about that in Canada when you've got 9 or 10 schools or faculties of pharmacy, but when half of your workforce has been educated by hundreds or potentially, 1,000+ different international institutions, What do we think about that? And do we think that that's going to help standardize offerings across the board? And what's that going to mean if we're not there? And then also, the elephant in the room being, there's been a lot. Pharmacy has never gotten more press than it's gotten in the last few weeks or last few months. How's some of this negative press related to quotas and services being rendered in cases where patients weren't even aware of it? How is this going to result in better compensation models if we haven't been treating existing services with some of the respect and consideration that they deserve across the board, recognizing that it doesn't take many people that are not providing a high level of service that's standardized. It doesn't take very many people to upset the balance for everybody. The old model that it only takes one student in the class to ruin a privilege for the entire class. Is that the same thing here? How are we going to deal with that when we've had fairly significant and widespread public issues in that area? And then wrapping up here, the case against the viability of the model is, if we look south of the border, even some of the most sophisticated corporations, Walmart and Walgreens come to mind, they have walked away from service provision in healthcare. They've shuttered clinics. They just don't feel that they can make money doing it. Now, obviously, it's a very different healthcare model there, but some of the reimbursement challenges are the same. And if they're walking away from it with their scale and their sophistication, is that really a very dark cloud for this happening at an independent pharmacy level or jurisdictionally in areas across the country here today? So now maybe turn this over and have a bit more of an open conversation from the audience sentiment. And is this a viable model there or not in your opinion? And is viability the key issue, or sustainability of the funding of services? Is that the bigger issue? What are some of the key points that we missed from both sides of the coin? When I say me, missed from both sides of the argument. And I'm certain there are many that were missed. In the sake of time, we couldn't be entirely exhaustive. And then lastly, if there's a sentiment here that we're still quite a distance away from the viability of a pharmacy service-centric model, then what are some of the biggest immediate barriers we can tackle? And then more importantly, from a University of Toronto standpoint, from a CPE standpoint, where can we step in to try to move this conversation forward in a productive and a constructive fashion, so that we're not waiting 15 years to come back and see where we've gotten to from there. So maybe with that, Annalise and Zubin, I will turn this back over. I'll stop sharing my screen and I'll invite, and there may not even be questions. It may just be commentary from the audience. It may just be some different points of view. But if anybody's got something that they want to sort of add to the conversation, by all means. And please, you're not offending me if you want to push back on anything that was presented there. I'm just trying to do my best to show both sides of the argument and both sides of the coin. But if you feel some of that information there may have been off the mark, by all means, I'm happy to respond to anything or just facilitate a bit more of a broad conversation.
Thank you so much, Mike. We do have questions, so I will say that. There's a few questions in the chat already. Just before maybe dive into Anne's first question, I'd just like to say that I attended the Canadian Pharmacists Association Summit today online, virtually, and I am astounded at how much of the conversation that I heard online during that summit was reflected in your presentation today. Everything from talking about some of the attrition rates for registered pharmacy techs, pharmacists in Canada, the role of the media in sort of, generating awareness about certain aspects of pharmacy practice, and particularly your slide about pharmacy versus pharmacists. So I would just like to point to that. I think you could have easily had a seat at the table there today. Maybe just looking to Anne's question, and I'd like to make sure we can get through as many of these as possible. Curious if you could expand a little bit more, Mike, depending on how much you know about what we could learn here in Ontario from the Alberta model, if it's been successful. Is it worth adopting or adapting some of the work that's been done there? And with the current or potentially future Ontario governments, would they be receptive to some of the work that's been going on there?
I think it's an amazing question. And by the way, my wife is a University of Alberta pharmacy graduate who started practicing in Alberta, and so it's a jurisdiction I have a good amount of familiarity with. I would say that probably the most important thing we've learned over the 20 years is that there have not been cases of significant, that I'm aware of significant liability legally to any pharmacist who's been participating in this area. And I think that's something that we really need to be talking about more, because I think it's an appetite for risk is going to potentially be a big limiter. And I think one of the really positive outcomes has been, I don't recall seeing anybody who was practicing with the right intent and doing things and doing something better for their patients, who was ever put in a situation where they were legally liable for something that happened to a member. And I think that's hugely important that we start to think about that a bit more. I would say, I don't know that we can look too much beyond what's gone on for the first 15 years or so of the Alberta model, for the simple reason that it really only started to take off in the pandemic. And that's when the number of pharmacists were like, I should really get involved with this, because I think a lot of pharmacists figured, hey, we may be working remotely for an extended period of time, if not permanently. And we're going to not be able to do much for our patients if we don't find ways to be able to, to go A through Z for them. And so I think it's now that will be really interesting to see in the next few years, Annalise, what's happened there, because you can't make much of the model when fewer than 50% of the pharmacists were actually engaged in the program. But more importantly, I do know from that Alberta model that it very much followed Pareto's law. In fact, maybe even more extreme, that there were a very, very small number of APA accredited pharmacists who were actually going through and doing it. And there was a few in particular that were almost like super users, kind of like you see in Airbnb, that were the ones doing the vast majority of the prescribing. And so I think the problem is, because it wasn't widely used up until fairly recently, and it was very imbalanced, we don't have really good data yet on what that means. But I think going forward, we will. And I think maybe there's an opportunity for the University of Alberta and the University of Toronto and other schools to get together, because Alberta does have better centralization of information. And so we may be able to put some heads together to think about research design using their data and not being worried about Ontario data, which is very limited in many, many areas right now today.
Yeah, I think that's a great point, Mike, just about, sharing. I think sometimes people focus a lot on sort of provincial differences and how to adapt things, entirely, but I think there's a lot of sharing that could take place. Zubin has a comment and a question, just as a follow-up. Did anything surface with respect to artificial intelligence technologies, potentially on one or both sides of the debate?
Not yet, Annalise, because AI in pharmacy and in healthcare today is so in its infancy, and I think it's being mislabeled. So it's like, oh, we've got AI here. That's great. It's a tool, but it's not yet entirely validated, and there's a lot of work to be done. And I will go back to the event that the university hosted. I believe it was last month, where we talked about AI and big data. And I remember being in that room on the 12th floor, I think, or 8th floor of your building, where one of the presenters, one of the pharmacists, brought up an AI tool and just basically created patient information using AI on the spot. I was watching the audience, and there was a noticeable, I would say, almost discomfort, because here was this AI tool effectively putting together a customized patient information sheet about having missed a dose, of what to do if you've missed a dose of contraception. And there were some people really intrigued at, wow, look at how you can just use that and it's so easy. I think a lot of people were also like, oh boy, is this technology going to put some of us out of business? Because we're not going to need a pharmacist if we've got some of these really, really thoughtful AI LLMs that have been effectively enhanced over time. I think right now today, it's early days for AI in healthcare in general and in pharmacy, but it's obviously not going anywhere, but it's early days. So it's not, I don't think it factors in immediately, but what I do think it does, Annalise, is it sort of, I think it provides a warning to pharmacy that was never there before, that if we do not start solving some of these issues ourselves and using some of these services and being able to bring them out to people en masse with the infrastructure we have in place and the accessibility we have, eventually we run the risk of technology taking over a big chunk of that, even though healthcare is intended to be very personal and things like that. The biggest asset pharmacy has is its accessibility and scalability, but we've kind of got to get going on that sooner rather than later. Otherwise, I think we'll back ourselves further into a corner. So I hope we get there soon.
Yeah, thanks for that, Mike. There's just a comment from Connie, and then a question from Katya, and then I'll turn to Anne, who has their hand up. Connie just sort of has a comment, Mike, if you want to expand or elaborate on anything. If the present model is not viable or sustainable, should we be exploring how we can change the model, e.g., separating dispensing from direct patient care?
I think the only challenge there is we need pharmacies to be physically an outlet where people can be seen and access services in person, access medication, over-the-counter products and devices and things like that real time when they need it. And so the problem is how does somebody develop a roster of patients for whom they can provide services if they are not a pharmacy, if they haven't recruited those patients by themselves? Now, if somebody's recruited a bunch of patients who are cash paying patients who are seeking them out online and paying them a consultative fee like they would to a therapist or some other professional, or like they would to to somebody doing private training at an athletic facility, there's nothing to stop somebody from paying $150 an hour to a pharmacist to say, listen, I need you to come over and spend an hour with, my loved one and figure this out, and I will pay for it out of pocket. If somebody's developing their own client roster there, that's great. Then more power to them. However, if they're requiring partnering with a pharmacy to provide services to an existing roster of patients who are suboptimally managed or who need help, then how do we make that division? And how does that division fare? Because again, we go back to the idea that if the compensation structure isn't really there today, where you can share some of that revenue, then I think the only way, Connie's point's an excellent one, but I think the only way that happens is if there's appropriate reimbursement for the dispensing side and appropriate reimbursement from that side, and we figure out how you share in the middle from where these patients come from. But I don't know that we can say it's appropriate dispensing revenue if it's gone up by 1% per year for 20 years. So that's where the challenge is going to come from.
Yeah, thanks for that, Mike. Katya has some great comments just about sort of things on the Nova Scotia front, some of which were echoed as well in this morning's presentation at the CPHA Summit. If Anne is still online, I'd maybe like to just flip it to you if you'd like to unmute yourself and ask a question or make a comment.
Hey, you guys can hear me?
Yes.
Yeah.
Okay, great. Yeah, no, it's an interesting discussion. I just want to go back to your point about AI. So the presentation was actually done by Michael, who I actually work for now, so at Medicist. And he's a very big proponent of AI because it's almost like it is the future. So we need to get ahead of it and we need to learn it now before it comes to us, when we're not ready. And the other thing I'll say with the discomfort piece is, I think even though it is, kind of weird to have this bot generate all this information for you, we've taken strides to make sure that it is coming from a validated place. So, the info that we feed it is validated by physicians, by clinicians as well. Though, of course, it's not 100% accurate. That's why it goes through a healthcare professional, but it will save some time. So, those are my comments on the AI piece. I think it's definitely a big help, especially if you are, super busy trying to counsel 100 people in a day, right? Save you some time there.
Michael was incredibly impressive in that performance. I had a chance to moderate that panel. He was incredible. He's just a fascinating person to talk to. And he made that very clear to the audience. He's like, everything we do is a tool that's there for the pharmacist, but the pharmacist takes it, they modify it, they decide what they want to keep, and they have the conversation with the patient. And he was right that, you know, some of these large language models they're not ready for prime time to do on their own. It's, you know, we're not quite at, you know, sci-fi world yet, but it was amazing to see what you could do with some of those pieces on the fly. My concern, Anne, is I think it would be fairly easy to say that, you know, if you go back to the 1990s and the 2000s, you know, when the revenue model was much, much more, you know, significant, the margins were higher, then you're in a world where you don't have to worry too much about some of these challenges because things are good and instinctively we're human beings. And if times are good, we don't really worry about when times are bad. The concern here with services is there's so much more that has to be done to scale them and deliver them properly than it is to dispense a product, that we have to be ready for it. And my concern is if we get down the road 10 years from now, and some of these LLMs and related tools are so much more sophisticated, we could run the risk of really effectively making ourselves a lot less valuable in the process if we haven't learned to bring the technology in and engage with it and embrace it, like you said, as part of the workflows. If we don't do anything and get further off and further ahead, then that's a real risk. Then I think what ends up happening, there will be players out there that will see value in trying to displace the labor model through that. But your point's well taken. Michael was very clear that their model is pharmacist-centric, you know, and it's wonderful. It's a very good tool. I just think as a warning for pharmacy in general, pharmacy's been looking at, you know, and again, I go back to being the son of a pharmacist. Pharmacy's been sort of looking ahead to the day that, you know what, someday things are going to really change. And those days are here right now. Between the pandemic and between technology, there's no more putting the genie back in the bottle. And so we need to figure this stuff out. And that's why I have to say it was almost a little bit stunning that some of this framework activity that happened in 2011, I mean, that should be the sole focus right now. There has to be a lot of work go on in this area, because if we don't get there, to your point, Anne, that's not a good place for pharmacy for sure.
Thank you. Thanks, Anne, for that question and comment. And thanks, Mike, for your response. I cannot believe we are over an hour. This discussion's been incredibly rich. And Mike, I'd like to thank you for doing such an eloquent job of presenting, you know, the case for both sides of the argument, but I just really appreciate the amount of research and well thought out planning that went into this presentation today. And as I mentioned, it was a bit of a different format for us, but I personally feel like this has been quite successful. I'd also like to thank everyone who joined us online. I'm sorry to cut the conversation short because I know there's a lot more that could be said on this topic. But we'll look forward to engaging with all of you when we resume our speaker series back in October of this year. And I will just say further to Mike's, you know, comments throughout the presentation today, if there are other thoughts, comments, questions that you have following this event, please do send them to me. I'll throw my email into the chat for those who may not have it. But we'd love to hear about you, hear from you, and just also, like Mike mentioned, think about how we can move this forward here at the University of Toronto and the Faculty of Pharmacy specifically. Thank you so much, everyone. Wishing you all a lovely rest of the afternoon and evening.
Thank you all very much, and see you in September.
Thank you all.